Good morning, friends. And today we have Department of Clinical Hematology presenting their experience on bone marrow transplant. Unfortunately, we don't see many audience, not even from their own department probably. And it's mainly, I think, because of the holiday being declared yesterday. So everybody is still in a holiday mood. And we hope people will join in as the time goes by. So they probably would be discussing use of hematopoietic stem cell transplant both in malignant as well as non-malignant conditions. And I think it's an important thing for an institution to have this program, which should be active and with good success rate. Thank you. Over to Sanjeev.
A very good morning to everybody present here. We already know that in this era, hematopoietic stem cell transplantation has progressed by leaps and bounds. Not only are there increasing numbers of success rates of HSCTs, there is also a falling trend of morbidity and mortality. In today's CGR, we will be expressing how we have kept pace with the changing landscape of hematopoietic stem cell transplant and our SGPGI experience. A brief overview of our presentation. Stem cell transplantation will be discussed under the clinical aspect as well as the laboratory aspect. We will be discussing a few interesting cases, and thereafter we'll be discussing data. So coming to a short history, the first xenograft was first described in 600 BC in Egypt, where a chimera was described who had the head of a lion, the body of a goat, and the tail of a serpent. The first documentation of skin grafting was done in the papyrus Ebers in 1500 BC, and in India, the father of surgery, Sushruta, has done the first skin transplantation. In 1853, the first organ transplantation was the kidney, and this was the team by Joseph Murray. The interest in bone marrow transplantation started after the bombings of Hiroshima and Nagasaki, where they documented that the survivors had bone marrow failure, and the first mice model showed that protection of the spleen prevented this bone marrow failure. Thereafter, during 1940s to 60s, the first transplantation was done by E. Donald Thomas on 6 patients. Although all his 6 patients died, he still received Nobel Prize for the same in 1990s. During 1960s to 80s, there was first description of conditioning regimens, chimerism was explained in detail, and 73 leukemia patients were transplanted for the first time. During 1980s and 2000, we had alternative methods of bone marrow sources like the use of peripheral blood and cord blood. And the first manganese anemia was transplanted in France. There was also a description and further interest in T-cell depletion for prevention of graft versus host disease. What is bone marrow transplantation? When do we do it? Who are the donors that we choose? Where is it done? And how is it done? I'll just briefly be explaining. What are the sources of hematopoietic stem cells? Right at the beginning, bone marrow was used as the source. However, it's an extremely painful procedure. It requires general anesthesia and documents the least amount of graft versus host disease. Peripheral blood has now started increasing in numbers, where it has a faster recovery period. There is no need of general anesthesia. However, it has slightly more GVHD chances than that of a bone marrow source. Cord blood transplantation is gaining interest. Why? Primarily because, one, there is less amount of HLA mismatching, and however, we require multiple cord blood donors in this case. What are the primary indications? Most commonly, bone marrow transplantations are done for both hematological as well as non-hematological conditions, for both benign as well as malignant cases. And within benign, mostly it is almost considered curative in case of thalassemia, sickle cell disease, aplastic anemia, as well as multiple malignancies like acute leukemia, lymphomas, and multiple myelomas. There are non-hematological indications like pediatric solid tumors like Ewing sarcoma, as well as neuroblastoma. And immunological, the first documented transplant was that in a Wiskott-Aldrich syndrome, as well as primary immunodeficiencies. We also do it for metabolic disorders like storage disorders, as well as adrenoleukodystrophy. Other neurological conditions like multiple sclerosis have also been found to benefit from a transplant. What are the different types of transplant? primarily autologous, where the patient himself is the donor and the stem cells are harvested from the patient and reinfused into the patient. The second most common type happens to be an allogenic transplant, where a healthy donor is used and his stem cells are collected and harvested and transfused into the patient. And the third type happens to be from an identical twin. What are the broad headings of types of transplants? We basically have autologous and allogenic, like I mentioned. In this, the most commonly preferred happens to be an HLA identical matched sibling donor. And thereafter, there is an increased number of transplants in matched unrelated donors and HLA mismatched donors, also known as haplodonors. HLA typing is only done for allogenic transplants, and my colleague Dr. Anu will be explaining this in detail. How do we choose our donors? Preferably, like I mentioned before, it should be a matched sibling donor. An 8-on-8 or a 10-on-10 match can be used. The donor age, a younger donor is preferred over an older donor. CMV status, preferably the patient as well as the donor should both be negative, with the highest risk of CMV associated complications if the donor is positive and the recipient is negative. In gender, we prefer a male donor over a female donor, and out of all of them, ABO incompatibility happens to be the least important. So primarily, we have a state-of-the-art transplant unit on second floor in I block. It is HEPA filtered, positive pressure rooms, and we have a 10-bedded unit for the same. So how do we proceed with the bone marrow transplantation? The most important thing is a pre-transplant workup, where there's a host of screening that we do for the donor as well as the recipient. In this, we try to mobilize the donor, and after mobilizing the donor, we harvest the stem cells, the CD34, from the donor. We give the patient a high-dose chemotherapy, also known as conditioning, and thereafter, we do a stem cell infusion that we have collected before, and we wait for engraftment and thereafter follow up the patient. So how do we proceed about it? We first mobilize the donor. That means that we give GCSF at a dose of 10 microgram per kg at a BD dose. And in case he does not mobilize very well, we also use plerixafor. Thereafter, we insert an IJV and we harvest the apheresis product. And based on the harvest material and the conditioning protocol, we can either refrigerate it at 2 to 8 degrees and use it as a fresh product, or we can cryopreserve it in liquid nitrogen. A high-dose chemotherapy conditioning is given. Stem cell infusion is done, and that is known as day 0. We wait for an engraftment period, and thereafter we monitor the patients for complications. The first 2 steps in a case of an allogenic stem cell transplant of mobilization and apheresis happen to be done on the donor, whereas subsequently chemotherapy, infusion, engraftment, and monitoring happen to be on the recipient. So what are the common complications? Post-allogenic stem cell transplant, neutrophils happen to be the first to be recovered, of which peripheral blood neutrophils recovery occurs at around 14 days. And the last to recover happen to be CD19 positive B cells, which take almost up to 2 years for recovery. And based on this pattern, we see a host of common infections based on the engraftment period. Of these, in the pre-engraftment phase, which is less than 30 days, because of the neutropenia and the chemotherapy regimens, there is a high grade of mucositis and Klapshi, along with an acute GVHD that we have to watch out for. There is a high incidence of infection in the early post-engraftment period, especially viral reactivation of CMV as well as varicella zoster. During late post-engraftment period, after 100 days, we are mainly watching out for chronic GVHD. So the lab aspect will be taken over by Dr. Anu. She'll be explaining how important the laboratory is in case of hematopoietic stem cell transplantation.
Good morning, everyone. So I'll be discussing the laboratory aspect of stem cell transplantation. So as my colleague has already told the steps of transplantation, coming to the first step, that is the pre-transplant workup, that is selection of the potential donor. So compatibility testing between donor and recipient is done based on the HLA antigen or the MHC complex that is present in the short form of chromosome 6. And this is the unique identification marker for every individual, as it is composed of highly polymorphic genes. So for HLA typing, the dictum is that better the match, better the outcome. It can be an 8x8 match or a 10x10 match, depending on the number of alleles we are testing between the donor and the recipient. For optimal transplant outcome, high resolution testing is crucial as low or intermediate resolution typing could mask additional mismatches. So previously, serological approaches were used which were based on complement-dependent cytotoxicity. However, these give low resolution typing, means we are able to identify the gene and allele group. However, we cannot decipher the protein or the coexisting DNA substitution. So with the further advancement, we have molecular methods that include the sequence-specific primer, that is SSP, and the sequence-specific oligonucleotide probe, SSOP-based PCR method, which have low to intermediate resolution typing. And then the next generation sequencing-based typing, which allows the precise identification of HLA allele and also the sequence of proteins specific for antigen binding site. So using those techniques, we can identify the gene, allele group, protein, and also the synonymous DNA substitution. This is called high resolution typing and the ultra high resolution typing. So once we have identified a potential donor, we move on to the next step, that is stem cell collection. So this includes the stem cell harvesting, enumeration, and cryopreservation. So what are stem cells? These are basically the hematopoietic progenitor cells present in the bone marrow, which have a capacity of self-renewal and differentiation into different cell lines. And CD34 is an antigen present of stem cells. So using an antibody against CD34, we can identify the stem cells. So once the bone marrow is stimulated using GCSF or Plerixafor, the stem cells get mobilized into the peripheral blood, which are then harvested and sent to the laboratory for count. So count, this is a critical parameter for engraftment as it is required for those protocols for transplantation. It is done at various time points during pre-harvest to monitor the harvest time, during pre-harvest to monitor harvest time, mid-harvest and post-harvest to determine the volume of sample that has been harvested and to ensure that we have sufficient cells for engraftment. As per recommendations, 2 into 10 to the 6 per kg body weight is the minimum. However, for better outcomes, a value of 4 to 5 into 10 to the 6 per kg body weight is acceptable as it gives better outcomes and lower incidence of infections and mortality. So currently in our laboratory, we are doing flow cytometry-based CD34 stem cell enumeration, which is a single platform method based on the international ISHAS protocol. And these are commercially available as kits and take around 30 minutes for the complete procedure. These are the dot plots of flow cytometric analysis of CD34 enumeration. The red dots are the stem cells and the pink population are the granulocytes and the monocytes. And this formula helps us to calculate the viable 34 positive cells per microliter. So once we have done the harvesting, we have the harvested product. Then we proceed for the cryopreservation, which is essential to maintain the quality and viability. The product is best used fresh and transient as earliest as possible. It can be stored up to 72 hours at 228 degrees Celsius. For long-term storage, it is stored at -150 to -190 degrees Celsius by using liquid nitrogen. Also, before re-infusion into the recipient, we check for the viability by using the 780 and the Crypan blue dye. So, after stem cell collection, the patient receives the conditioning. The stem cell infusion is done, engraftment takes place, and then we do the chimeric analysis. So basically what happens when we give high dose chemotherapy or conditioning to the patient is myeloablation and the patient undergoes a stage of bone marrow aplasia when the normal cells, the abnormal cells die and then the stem cells are reinfused. So it takes around 12 to 15 days post-transplant for the neutrophil and platelet recovery to start. This is called engraftment and is defined as a peripheral blood absolute neutrophil count of more than 500 per cubic mm for first 3 consecutive days and a platelet count of more than 20,000 for 7 days without any requirement of any platelet transfusion. Then we proceed for the chimeric analysis, that is monitoring the percentage of donor cells in the recipient, which is called donor chimerism. This is done by analyzing the peripheral blood samples. This is fundamental for predicting negative events like disease relapse, graft versus host disease, rejection, and to initiate an early effective therapeutic intervention. There's various methods of chimeric analysis like red cell typing, restriction segment length polymorphism, cytogenetics including FIS, STR, PCR, and next generation sequencing. STR, PCR, that is short tandem repeats coupled with capillary electrophoresis, is a high power of differentiation between different individuals. Short tandem repeats are basically short repetitive sequences of oligonucleotides, and the number of repeats vary from person to person. That's why these are like a unique identity for every person. We have around 16 STR markers, out of which we identify the informative and the non-informative markers. Non-informative, the ones shown in blue arrow, are the markers which will be similar in both the donor and the recipient, and that's why they won't give any information about the donor cells and recipient. whereas the one highlighted in orange are the markers which are different in the donor and recipient. And so the last electrophoregram shows that the patient is now expressing the donor cells as it is giving the same allele type that of donor. So that is how we do the chimeric analysis. So once we have done the chimeric analysis, now in cases of transplantation, for the indication of some malignancy like acute leukemias or lymphomas or myeloma, we also need to assess and if there is any residual disease or any tumor cells still persisting in the bone marrow that can give rise to relapses. So that is done by using MRD analysis. Minimal residual disease, also called measurable residual disease, by definition, it means the disease not detectable by light microscopy. So this is a figure showing the number of leukemia cells that might be persisting in the bone marrow corresponding to the MRD level. So by microscopy, we do the morphological assessment and we can pick up the disease cells with sensitivity of 1 in 100. However, if the tumor cells are less than 1 in 100, we cannot identify them with a light microscopy, and we need techniques with higher sensitivity to identify the disease. So the various techniques of MRD analysis beyond light microscopy include the multicolor flow cytometry, which is rapid, cost-effective with a sensitivity of 1 in 10 to the -4 to 10 to the -5, and the molecular method like the PCR-based method with a sensitivity of 1 in 10 to the -5, and then the next generation sequencing with a sensitivity of more than 10 to the -6. Currently, we are doing all methods for our patients. Next, I'd like to invite Dr. Deep to discuss some cases.
Good morning, respected teachers and dear colleagues. So I will be discussing about a few interesting and challenging cases which we had transplanted successfully at our institute. So beginning with the first case, which is of a 16-year-old male who presented to us in March 2020, had a marfanoid habitus on examination. The patient had come with a persistent high-grade fever spikes for 1 month, had bilateral cervical lymphadenopathy. His hemogram showed pancytopenia with TLC being nearly 670 cells. So with this, we proceeded with his bone marrow examination. Like we see here, the bone marrow was filled with these blast cells. Hence, a diagnosis of acute leukemia was made. But for better characterization of the type of the acute leukemia, we proceeded with a flow cytometry-based analysis. So the flow cytometry, like we see here, showed two distinct populations of the cell. In this graph, we can see the yellow population, which is a CD19 positive population, is of the lymphoid cells, that is a B lymphoid, and a red population, which is a CD19 negative population, is of the myeloid. So two distinct blast populations were seen in this patient. So a diagnosis of mixed phenotypic acute leukemia, which is of the B myeloid type, was made. So mixed phenotypic acute leukemia is a extremely rare disorder, being for less than 3% of all the acute leukemias. And as per the standard guidelines, the patient was initiated on a lymphoid predominant based induction regimen using the BFM95 induction protocol, which includes 4 drugs: steroid, vincristine, daunorubicin, and L-asparagines. Post-induction, his bone marrow was repeated. At this time, there were no lymphoid blasts, but the bone marrow showed persistent of 10% of myeloid blast. For us to say a complete remission, we need a blast count of less than 5%. But this patient had a persistent of 10% myeloid blast. So to tackle this problem, another intensive induction therapy, that is a flag IDA therapy, was given to this patient. Post this therapy, the patient achieved the MRD negative, that is the measurable residual disease was negative in this patient. But unfortunately, due to a COVID pandemic, this patient could not follow up regularly with us, and he presented to us 2 years later. At this time, had a similar complaint on presentation, and his bone marrow was repeated, which showed a 42% blast. Hence, there was a relapse of the disease. So at this time, again, he received an intensive chemotherapy regimen, that is a hyper-CVAD regimen, which contains fractionated dose of cyclophosphamide along with vincristine, cytarabine, and daunorubicin. So bone marrow examination was repeated after this intensive regimen. It showed blast count of less than 5%, but his measurable residual disease was still detected. That is, 7 abnormal cells were detected out of the 10,000 cells. So to tackle this problem, the novel drug of inotuzumab ozagamycin, which is thankfully available at our disposal, was used. Inotuzumab ozagamycin is an anti-CD22 monoclonal antibody, which is conjugated to a drug called ozagamycin. It is the entire complex gets binds to the CD22 molecule on the receptor on the surface of the lymphoid blast, and the molecule is then internalized. After internalization, the ozagamycin is released from this antibody, which is toxic to the DNA of the blast cells. Hence, using this inotuzumab ozagamycin, we were able to attain a MRD negative status for this patient. The post MRD negativity, the patient was taken up for matched allogenic sibling stem cell transplantation. Thankfully, the patient had a 10 by 10 matched sibling donor. So for this patient, a conditioning regimen of fludarabine and melphalan was used. Simultaneously, donor mobilization began with using GCSF, followed by stem cell infusion was done. Currently, patient is 60 days post-transplantation and continues to be in complete remission with 100% donor chimerism. That is, the entire hematopoiesis is of the donor origin now. So from this case, the things to learn were the refractoriness of the disease, that is of the mixed phenotype. Because it was a mixed phenotypic variant, we couldn't use a particular chemotherapy regimen. So the disease was refractory. And also after a intensive regimen, his MRD was still positive, which was tackled with a novel antibody drug conjugate. Moving on to our second case, which is of a 14-year-old female who presented in September 2021 with easy fatigability, mucosal bleeds for 2 months. And on hemogram, she had a pancytopenia with HB being 5.5, TLC of 1900 and platelet nearly 18,000. So for this, we then went ahead with a bone marrow examination, which showed that entire bone marrow was replaced by fat cells. Hence, the diagnosis of severe aplastic anemia was made in this patient. So for severe aplastic anemia, at this age, the ideal treatment would be a matched sibling allogenic transplantation. But for this case, a 10 by 10 match was not found. Hence, an immunosuppressive therapy with cyclosporin and anabolic steroids was begun for this patient. But patient did not respond to this therapy and she continued to receive multiple transfusions. So we proceeded with a haploidentical allogenic transplantation. A haploidentical allogenic transplantation for aplastic anemia is very difficult because it is a benign disorder and a haploidentical transplant will have a more GVHD effect, which we absolutely do not need in this patient. So a patient had a 6 by 10 match on transplantation, but this was not just the only problem. The other problem was that the patient was blood group O positive while the donor was of B positive. So this was a major ABO incompatible transplant as well. So for major ABO incompatible transplant, we follow a specific transfusion strategy. The phase 1 is the phase that is when the it is a pre-stem cell infusion phase. So that is the phase of the mobilization and conditioning. So in this phase, all the products to be transfused are of the recipient blood group. Phase 3 is the phase when the engraftment has already occurred and now the recipient has the blood group of the donor. So the PRBC transfusions are of that of a donor blood group in this phase, while the platelet transfusion again are of the donor blood group. The main problem lies in the phase 2, that is from the day of stem cell infusion till the day of engraftment has occurred. So at this time, the RBC product are to be transfused of the recipient blood group, while the platelet products, plasma products are to be transfused of the recipient blood group. The main idea is as the patient is harboring antibodies against the antigens, so we should not feed the similar antigens, that is the RBCs to the patient. Also, we check for an antibody titer beginning at the day 4 and until the antibody titers is less than 1:16, we say the engraftment has occurred. So using this specific transfusion strategy, then we proceeded with the haploidentical allogenic transplantation. As I said, that main problem with the haploidentical transplant in a benign disorder is a more risk of graft versus host disease. So for this disorder, we absolutely do not want any graft versus host disease. So a specific GVHD prophylaxis using a triple therapy is used for this patient. Usually we use a dual GVHD prophylaxis, but for this, we use a triple GVHD prophylaxis using post-transplant cyclophosphamide, which is given at day +3 and +4 post-transplantation at 50 milligram per kg, and along with mycophenolate mofetil and sirolimus. So with this, transplantation was carried on and currently patient is day +240 post-transplantation and continues to be complete remission with normal blood counts and 100% donor chimerism. So moving on to our third case, which is of a 48-year-old female who presented to us in April 2022 with shortness of breath, swelling over both feet, pedal edema. Essentially, patient was in fluid overload. On evaluation, patient was found to have anemia, thrombocytopenia with a advanced renal failure of serum creat being 7.1. So initially, this patient was admitted at our nephrology ICU, was on NIV support. On further evaluation, her peripheral smear was found to have 14% circulating plasma cells. Like we see here, these are the circulating plasma cells here. Also, there were rouleau formation like we see here in the peripheral smear. So myeloma was suspected, and as there were 14% circulating plasma cells with a absolute plasma cell count of 2,800, a diagnosis of primary plasma cell leukemia was made. Further analysis showed that bone marrow was filled with these plasma cells, and these are the FISH study reports which showed translocation 414 and 1Q gain. So these are the markers of a high-risk disorder. So plasma cell leukemia is an extremely aggressive disorder with an overall survival of only 6 to 8 months, and 30% of the patients die within the first month of the diagnosis. So for this aggressive disorder, it has to be treated aggressively. Usually we use a triplet regimen for myeloma patients, but for plasma cell leukemia, we had to use a quadruplet regimen to tackle the aggressive nature of the disease. So this was done using daratumumab, which is a monoclonal anti-CD38 antibody, along with bortezomib, cyclophosphamide, and dexamethasone. So after 4 cycles of this quadruplet regimen, a complete, that is a very good partial remission was attained. That is more than 90% reduction in the monoclonal protein level. So this was then consolidated using an autologous transplantation. But the problem here was, as a highly intensive regimen was used and patient was immediately taken up for transplantation, the stem cell count was very low. So for this, we had to mobilize the stem cells using GCSF along with plerixafor. So this mobilization was used for this patient. Conditioning with melphalan was given, followed by the stem cell infusion. Currently, she is post-month 8 months post-transplantation and continues to be in complete remission with no measurable residual disease. So these were the few difficult cases which we had to tackle, and we did it successfully. Thankfully, to novel antibodies available to our level at our disposal, and also the lab support which we have. So now I request Sanjeev sir to present the data of our transplant unit.
Good morning, everyone. In SGPGI, bone marrow transplantation program started way back in 1999, when first autologous stem cell transplantation was done. First allogenic transplant was done in year 2000 for the indication of aplastic anemia. First haploidentical transplantation was done in year 2017. That patient was a myelodysplastic syndrome, excessive blast, and that patient is still in remission and he is doing well. The first mud transplant we did last year for the indication of acute lymphoblastic leukemia, and we have not done any cord blood transplant or syngeneic transplant, and till date we have completed 165 bone marrow transplantation. We were the 8th institution in India when we started the transplantation. Our center number, we are reporting all our transplants to the Indian Society of Blood and Marrow Transplantation Registry, as well as APBMT Marrow Registry. Our center number is 108. This is the ISBMT registry data, in which we can see each year how many transplants has been done. In year 2021, there are 2,498 transplants. This is the in the left side we have our transplant results. Before 2016, we have did 55 transplants. Initially, we have only 4-bedded transplant unit, which has poor infrastructure. Unfortunately, after inauguration of our new facility, COVID wave come, and we were not able to start our program in 2019. But after the second wave of COVID, we started increasing the number of transplants. In year 2021, we did the 23 transplants. In year 2022, we did 39. This year also we have completed 8 and expected to increase the number of transplants. Regarding allogenic and autologous transplants, we have done allogenic transplants 83, autologous transplants 74, and mud transplant 1 and haploidentical transplant 7. The mud transplant was, as I previously told you, it is for the acute lymphoblastic leukemia. For haploidentical transplant, we have done for MDS, severe aplastic anemia, and AML. This is the data for the individual disease-wise indication, and the maximum number of transplant that we have done, it is for aplastic anemia. followed by multiple myeloma 40 in number and acute myeloid leukemia 22, Hodgkin's and non-Hodgkin's lymphoma 13, chronic myeloid leukemia 10, thalassemia major 4, and there are multiple other indications as well. As we see the ISBMT registry data, the maximum number of transplant that has been done in India for the multiple myeloma followed by acute myeloid leukemia and thalassemia and followed by severe aplastic anemia. Unlike in the ISBMT registry, we have done maximum number of transplants for aplastic anemia. Thalassemia transplants are less in number. Recently, for past 2-3 years, our thalassemia patients have got funding by the Coal India, and we are hoping to increase the number of thalassemia transplants in coming years. Last year, we did some rare indications like primary AL amyloidosis, plasma cell leukemia, mixed phenotypic acute leukemia. Among NHLs, mantle cell lymphoma is the most. Regarding the outcomes, we have analyzed our outcome data for our aplastic and myeloma transplant. Other transplant number are less. That's why we are not able to analyze that. And we have a 5-year survival rate of 69.8% in our aplastic anemia transplant. We have mortality of 13 patients in our cohort. Transplant-related mortality is only 10%. Rest of the patients have died post-transplant with various complications. There is no clonal evolution in long-term follow-up. None of the patients has developed any clonal evolution. And the mean survival time of our entire cohort is 103 months. Comparing with the CIBMTR data from India, it is the total number of transplants in year 2001 to 2011 cumulative. They have reported the response in less than 20 years and more than 20 years. In less than 20 years, the 5-year survival is 88%. Children do better with transplant. That's why even they don't have max sibling donor, there is a recommendation to do haploidentical transplant for them, which is not followed by adult patient. And 72% is more than 20. So our survival rate is almost comparable. We have done more number of adult transplant rather than the pediatric transplants, and our cohort also includes the haploidentical transplant, in which obviously the outcome are not as same as the max sibling transplants. For multiple myeloma, we have a very good overall survival of 89.7% with a median survival time post autologous stem cell transplantation being 39 months. Very few centers have achieved that much of overall survival, except the Max group from by Rahul Nathani sir and TMH Mumbai. Otherwise, all have around 60 to 70% overall survival rate. So myeloma transplants are more in number because we have a referral bias. We have more number of multiple myeloma patients at our centers. With that, I acknowledge my department, especially our lab colleagues. Without their support, we cannot have such a program, because in bone marrow transplantation, we need some reports on the same day, like nephrolab gives us same day blood drug labels like cyclosporin level or tacrolimus level. Our own department gives us reports for CMV copy numbers, chimerism report in time. So that these things are important in decision taking for patients with bone marrow transplantation. And our clinical resident and lab resident, they definitely support us for this program. Our nursing team, which is doing a beautiful job for caring of the patients of bone marrow transplantation. Definitely, bone marrow transplantation is a teamwork, not a one-man show. And I acknowledge Department of Transfusion Medicine, Radiotherapy, Radiology, Nuclear Medicine, Pathology, Microbiology, Nephrology, CCM, Gastromedicine, Cardiology, Anesthesia, Pulmonary Medicine, Pediatric Gastromedicine, Biostats, and Immunology Department for helping in managing our patients. Thank you.